Shannon, I am thrilled that we are doing this today.
I have been looking forward to meeting you. I've been such a fan of all the information that you share and the loving way that you share it for so long. I'm so glad that I found you. In many ways, I think you don't realize this, but you were on my healthcare team as I was navigating breast cancer. So
I
thank you.
love that. Let's kind of dive right in and tell us a little bit about who you are and your story.
So I'm Shannon Klingman. I practiced OB. I was a board certified OB-GYN that practiced for about 15 years. And interestingly, I was a stay-home mom for about a decade. Had an idea when I was in my residency for a product that could control body odor everywhere in a really unique and novel way, and navigated the patent process and contract manufacturing and launched a brand. Lume Whole Body Deodorant is my company that I launched in 2017. And 3 years into that process, I had an exit where Harry's Mammoth Brands, the razor company, partnered with me. It was more of a merger, and I remained on as like an operating leader and face of the brand. But as my time there was feeling a little like we were growing to a point where I felt like I'd exceeded my level of competency and I needed to really hand over the reins to more experienced operators and fill the room with people who were better than me. I thought, what's going to be next for me? And I felt like I was 55 years old. This was just a year ago. And I was in my prime. I felt like I had just such bright opportunities ahead of me and trying to decide what was next for me. And when I asked myself that question, it was about 3 days before I was scheduled to go for my annual mammogram. And just over a year ago, I was diagnosed with microinvasive lobular carcinoma in my right breast. And so
Yeah.
that's what I've been up to for the last year is
And
managing that. So
and
that's
I
who I
think
am.
whether you know it or not, you have become such an advocate for lobular cancer and the lobular community.
What I realized really early on, even for myself, when I opened up the biopsy results and it said microinvasive lobular carcinoma, you could have knocked me over with a feather. It was just to my knees. Even though I've been in that position with patients before,
Yeah.
I have felt the gripping fear but the question that I had is, what in the heck is lobular breast cancer? Like, my sister had ductal when she was 40. I have a niece who had ductal. I have an aunt and a cousin who had ductal. So our family history is peppered with breast cancer, but lobular was a new one for us. And the more I dove into it, I realized that even among physicians, oncologists, and breast surgeons, they really lumped lobular breast cancer in with ductal and treated them the same way under the kind of the biomarker of like, is it estrogen receptor positive? And then that's the lane you're in now. And so I very quickly got in at the Mayo Clinic. I live here in Minnesota, and so I all my care was managed in Rochester. My initial biopsy was at a community hospital where my husband practiced medicine. And so when that biopsy came back positive, I have a sister-in-law who's an oncologist at Mayo. And so I felt pretty strongly that was where I needed to be, one of the top 3 cancer centers in the world. And but it was interesting, even at the Mayo Clinic, how I was really shuffled into this like, hey, microinvasive, this is a nothing cancer. Um, you don't really, we don't really, you're in, if you're going to get a cancer, this is a good one to get. And as my care, the next steps of my care took place, it became really clear to me that if I was not advocating for myself, I would have had a very different outcome based on my lobular histology.
And I think that's one of the things that, we're really starting to pay attention to is the incidence of lobular cancer is growing significantly. And we know these behave differently, they present differently, their biology is different. But I agree with you that the education is still, let's group them all together. And we
Mm-hmm.
know that these are different histologies and again, different outcomes, different, potentially even different treatment.
And one of the things that I think is the most terrifying for me in the beginning was that I received my diagnosis through a community hospital, had all my records transferred to Mayo, and they take their time. They're like, this is not an emergency.
Mhm.
We have a couple weeks to figure this out. This isn't like ready, fire aim. Let's figure out what our course is going to be. And I really appreciated that because it really lowered the temperature in the room for me. But as I was going through, they repeated all of my imaging studies, my mammograms and my MRIs. And the frightening thing is nothing showed up on imaging after my biopsy. The biopsy was for microcalcifications, which were a change, but my left breast was clear and there were no additional findings in my right breast. In fact, Mayo got in touch with me after they repeated all the imaging, and they had a pathologist review all of my slides. And he said, I don't see cancer here. I just see LCIS, or carcinoma in situ, which isn't cancer. And I do see lobular hyperplasia really throughout the biopsy, but I don't see any invasion here. Shannon, you don't have cancer. And this was on a Thursday. And then that following Friday, so just like 48 hours later, I had my consultation with the surgeon. And so I had heard no cancer, but we need to do a wide local excision. We're just going to make sure that that there's nothing more there that we need to be concerned about, because lobular can be multifocal, multicentric. And so they said, you don't have cancer. And my husband and I were like on our knees, like so grateful for this news, because even though it was still scary, it was risk factors for cancer, right? Versus just invasive cancer.
Yeah.
So Friday I go for my appointment and the nurse practitioner walks in and she says, okay, so we're seeing you today for invasive lobular carcinoma. And I said, oh, no, actually they called me yesterday and said that they didn't see that on the slide, and they had 3 pathologists review it and that it's just LCIS. And she said, no, I'm seeing here, there's an addendum to that. They actually didn't review the cancer slide. It was one slide among maybe 20 slides.
Mhm.
There was only one that showed the microinvasion, and it was less than a millimeter of invasion. But it was indeed invasive. And so I said, well, I need to talk to the breast surgeon, and I'd love to talk to my oncologist about what just happened, because yesterday they told me this wasn't
Yeah.
cancer and now it is, and I understand, but there was major whiplash there,
Mhm.
right? And so when the surgeon came into the room, I think what she was trying to do was reassure me that the difference between LCIS and microinvasive disease, it's just splitting hairs. And the words that she used were like, this is a nothing cancer. Like, you're kind of overreacting. This is,
Mhm.
we're going to go in, we're going to scoop this thing out, and it's going to be a little blip in your life and you're never going to hear from it again. And I said, well, if it's cancer, I feel like maybe right now I'm thinking bilateral mastectomies. Am I a candidate for skin and nipple sparing mastectomies? And they do nerve sparing surgeries at Mayo
Mhm.
Clinic. So I thought, just get all my histology out on the table and we're not going to miss anything, because isn't lobular like multifocal, and isn't there a risk factor that it's bilateral? I really didn't know as much as I know now at that time. And she said, yeah, but we're going to pick that up on, there's nothing on MRI. Your mammogram is totally negative. We'll pick it up because we're going to scan you every 6 months. And then any biopsies that we need to do, we're not going to miss anything. So they consented me for a lumpectomy and possible lymph node dissection, although she really was, I don't know if there's like been a change or there's some debate about when to do nodes and
Yeah.
when not to.
It's really
But
changing. To try to,
I
can
thought,
we do less, but in some cases, yes, but not all the time.
and I thought, lobular is probably not the one to mess around
Yeah.
with, right? And
Hmm.
they didn't have a lobular specialist there at Mayo, but they reassured me, oh, we take care of tons of lobular patients. And I said, yeah, but I'm not hearing the hey, it doesn't show up on imaging. So you're telling me that we're going to do a lumpectomy and there's a possibility that there's a coexisting lesion on the same breast and possibly a 30% chance of a contralateral breast cancer in my other breast. But we're going to do a lumpectomy here, even though imaging isn't great at picking it up. I don't feel reassured by that. So I wanted to do bilateral mastectomies. But I felt really, they were frustrated with me that that's what I wanted to do. And she said, we can always remove your breasts. We can always go back and do it in the future. You're doubling your risk of infection. You're doubling your risk of hemorrhage. You're doubling your risk of anesthesia, because the surgery is going to be double the time.
Yeah.
maybe even
Mhm.
longer. And then we had this debate about lymph nodes, and I just said, I want them because if something weird shows up on final path, I want to be able to be part of studies,
Yeah.
right? And
Mhm.
oftentimes you need to know your nodal status.
Yeah.
So she said, well, the internet's a scary place, and it's clear you've been doing a lot of reading. And just so you know, you're going against medical advice. This is not what we would recommend. Sure, we'll do your bilateral mastectomies, and but you're the one who has to look at yourself in the mirror every day with that. And you're going to lose your sensation. It's never going to be the same. We basically do nerve sparing just so you don't like harm yourself. It's not really intended to restore you to, you know, your breast being a sensual organ and all that. And I said, see, now I feel like you don't like me. I feel like you're so frustrated with me that I
Yeah.
made this decision that somehow like you're kind of undermining or like you're dismissing the fear that I have as if it's not valid. Would you agree that lobular breast cancer is a sneakier
Mhm.
breast cancer and that it doesn't show up on imaging? You often can't feel the lump. We don't have targeted therapies for it. And she said, yeah, whatever you want to do. But Shannon, this is at the end of the day, this is a microinvasive cancer. We're going to go scoop out. I can guarantee you your nodes are going to be negative, and you're kind of making a bigger deal out of this than you need to. Okay. I was like, whoa. Well, just humor me. So I went into my surgery with that sentiment
Mhm.
that I was way overcalling this thing and I was worried without reason. And that, yeah, lobular is different, but not when they're this small. And so I was fortunate enough, I think my surgeon technically was really amazing. And once she had resigned, you know, like, hey, this is the decision Shannon's making. She was incredibly supportive, as was my plastic surgeon, who was amazing. And they were able to accomplish the bilateral skin and nipple sparing. My intra-op pathology showed no residual cancer on the right side, but my breast was peppered with LCIS and lobular hyperplasia, as well as my left breast. But I was prepped for nodes on both sides because of my election. She said we got to prep it, but intra-op path was no cancer,
Mhm.
just these risk factors. And she only did nodes on the right. And my sentinel nodes were negative. She did 3. Then on the left, it was identical pathology with no cancer on the right.
Mhm.
So 2 weeks later, I get my final path back, and my surgeon calls me and she says, "There's been a change, and you made the right decision. You have a lesion on your left breast that is 6 times larger than the one that you had on your right. You had a 6 millimeter invasive lobular, classic type,
Yeah.
grade 1. My Ki-67 score was 5. My estrogen receptors were positive. My progesterone receptors were negative and HER2 negative.
Mhm.
And I said, see, like, what was that all about? That dance. I said, I think my case needs to be reviewed. I think that women need to understand that there's a 30% chance that they have bilateral breast cancer, even though it didn't show up on imaging, but as high as 30. I mean, you may disagree with me, but that was the statistic
Yeah.
that I was kind of rolling around in my head. And I said, would you board a plane if there was a 30% chance of it crashing? And then I was concerned about, you know, the cosmetic result of radiation. And I think I look back now and I think I received like wisdom from just binge watching lobular experts like Jason Moabi from MD Anderson, who
Yeah.
really,
Oh,
he
he's
doesn't
great.
know it.
Yeah. He's
He drove
fantastic.
he drove me to bilateral mastectomies, and I didn't hadn't met him privately yet at the time. But he said, you know, the one thing that we need to be having a conversation with our patients about is that if we're doing lumpectomy and radiation, that there is a chance that even as high as 30% that there is an additional lesion on the other breast. And then the nomenclature of the way we describe, so we'll say, hey, Shannon, that cancer in your right breast is not going to be, your outcome's not improved by removing your left breast. But if you get a cancer on the left, that's a new cancer.
Yeah. Mhm.
So the semantics and the nomenclature of it was, but it's one patient. So I'm grateful I made the decision to do bilateral mastectomies because I'm pretty hyper vigilant to the point of obsessing over things. I don't let things go easily. And I think I think I would have been tormented by the thought, what if, what if, what if, and how long until it shows up on imaging. So,
And I will say that you really pushed, and there's a lot of people who wouldn't have, right? Or would have said,
no.
okay, you know what? Maybe this is, I feel this in my gut, but maybe this is overkill, and I'm gonna go with the lumpectomy. And and I think that one of my goals, right, with this podcast is to share people's experiences so that hopefully other people feel empowered to listen to, to really, sometimes you have this feeling like this is what I need to do. And it's important that everyone is being heard and feels like they can advocate for themselves to pursue what they feel is right for them.
Yeah, and even when we say, the prognosis and outcome and disease-free interval, all that isn't impacted by mammogram or by mastectomies versus lumpectomy, so much of the research is powered by ductal data
Yeah.
that
Hmm.
we tease out lobular, and yeah, it might be statistically significant, but what the one thing that we do not know is for anyone who has a contralateral new cancer in the future or a local recurrence in the same breast after a lumpectomy, we will never know if that was present at the time of the diagnosis.
Exactly. And a lot of the lobular cancers, the classical types, these are not your fast growing triple negative cancer. And if you're going to go on endocrine therapy, that might control it for a while. So, I think
Mhm.
there's a lot of nuance, and you're right. I mean, when you look at data, one of the questions whenever I post a study, people always ask, well, what percentage of patients in this study were lobular? And often we're talking in the single digits if it's reported at all. And we do
Yeah.
know about 10% of cancers are lobular. Again, that number is rising, but 10% of how many breast cancers we see a year, that is not an insignificant number. That's actually going to be higher than some primary cancers, that occur in
Yeah,
different.
like cervical and ovarian,
Exactly.
but they keep
Hmm.
it combined, right? And
Yeah.
so the other piece of it that I've since really pondered and thought about at my most recent oncology appointment, I was interested in doing the cancer index,
Hmm.
uh, because I read your Substack that said that even though patients may be clinically low risk for recurrence, 40% of the time they are like upgraded to a higher risk status
Or they're
after that.
Yeah, or they're clinically low risk, but they benefit from that extended, endocrine therapy that stopping at 5 years may not be enough for some people.
Yeah, I think that's so I mentioned that to my oncologist and I asked for it early, even though knowing my insurance company won't pay for it. I think for me, and I think for other women too, it would be nice to know, are you looking down the barrel of 5 years of an aromatase inhibitor or 10?
Yeah.
Because I'm 1 year down and I have to say, oh my word, I am 20% through this and I'm doing okay. And the other piece of it that I think is important that I do meander, Eleonora. So I apologize for that. But when I was talking to my oncologist, she said one of the things is the cells, if there's any residual cells, that they can actually lose that they become resistant to the endocrine therapies over time. And so, even knowing that, I thought, wouldn't it make more sense to remove the tissue and consider, I'm an advocate for good cosmetic results, skin and nipple sparing, scoop out all the breast tissue. And to me, it feels a little like, you look in the mirror and you see the same nipples and the same skin and they are a little different shape, not necessarily worse, not necessarily better. And and yet I now know that even though there could be some breast tissue left behind, that we did our damnedest to remove the local disease, the primary
Yeah.
tumors, right?
And
And I'm not going to be looking at, hopefully, uh, them being resistant to the endocrine therapy, if they were to recur at a later stage, right? Because
mhm.
the cancer on that other side that didn't show up, I asked my oncologist, how long would you think it would be before that would show up on imaging? He said, well, you're on an aromatase inhibitor for the next 5 years. It could be 10 years
Yeah.
before that would have shown up on imaging. And by that time, it could be resistant to endocrine therapy. So other conversations to have that I think maybe not everybody thinks about.
Well, and I think that when we think about that preoperative, counseling and diagnosis and conversation, right, understanding what are the differences. I mean, there's all different types of histologies in addition to lobular and ductal that are much less common, but as we think about, or what is the cancer that we're dealing with? What is the behavior of that cancer? What is the biology of the cancer? The lobular versus ductal has to play a role in that conversation.
Yeah. Yes. And
Mhm.
I what I realized really quickly, even in talking to a group of oncologists about this, is that when I asked them, what would you do if you were me? The breast surgeons, what would you do if you were me? And they all pause and
Mhm.
say, I don't know what I would do. And so that tells me that the recommendation of lumpectomy and radiation, they paused on that, like, lobular. I'm not sure. And then after hearing my story, and then
Yeah.
I see like other longevity specialists, like I'm in like a longevity program there. And the physicians all say, oh, I would have done exactly what you did. I've already decided that if I get breast cancer, this is what I'm going to do. And I said, I don't know that you know for sure until
I don't
you're
think
in it.
yeah, I don't think because I agree with you. People always ask me, well, what would you do, right? And for me, it's more
Yeah.
the medical oncology decisions, right? Like we're talking about taking the ovaries out or doing ovarian suppression, or we're talking about tamoxifen or AIs, whatever it is. And people always say,
Yeah.
what would you do? And I say, honestly, I don't know. I've thought about what I would do, but I don't think you know until you're in that moment where you have to make that decision, because it's just, you can prepare all you want, but when you're in it, that's completely different.
And you realize every cancer is different, right? It's
Hmm.
everyone's situation is so unique, and the other comorbidities that we have. Um, I think that I think it's important though that as physicians we understand that those initial words that we speak to that patient
Yeah.
are so
Oh,
important.
yeah.
And when I asked my oncologist, what's like talk about survival percentages, like what are the chances I'm going to be alive in 20 years? And the study that they quote is like, what was it, published in
Oh,
2016? And
yeah.
the
If
data
not
collection
earlier.
was from 1960. And
Yeah.
as I read it, I thought, how is this even valid? Because half the women didn't even get Herceptin. We weren't using aromatase
Oh, yeah.
inhibitors for early stage disease. So, like, do you think anybody's going to update, or is that being
I
worked
mean,
on right
we need to. I mean, so many women here, and it still gets 1 in 3 women recur. I mean, this is a myth. I mean, it's not a myth, it's old data, but it
now? Oh,
gets
data.
the problem with it. It gets propagated in research studies where people are like, this is an unmet need because 1 in 3 people recur. And, it's being used to get funding and all that, but that data is very outdated. And you're right, it's based on 20 plus years ago, if not later, earlier, when we didn't have all the treatments that we have now. We didn't have all the
Mhm.
diagnostic techniques that we have now. But yet that statistic is so scary and it gets thrown around everywhere. And I really hope that, one of the things I write about in my book is when you hear those scary statistics, the first thing should be, what year are they from? Do they apply to
Mhm.
me? Right? If you're talking about a HER2 positive cancer, you can't use statistics before we had modern day anti-HER2 therapies.
Mhm.
And so I'm hoping it'll change. The problem is statistics, as you know, lag behind, and then there's always a new drug that comes along. And so
Mhm.
I think it's really thinking about on an individual level, what is your stage? What are the markers? What is the histology? What is the treatment? And what do we know about that in today's day and age? But I always tell patients how we treat cancer today is certainly not how we're going to treat it in 5 years, and it's not how we treated it 5 years ago. And so it's really evolving, especially with, novel SERDs that are coming, and that may replace aromatase inhibitors, and we think these may be
Yes.
better
Yes.
drugs, right? So that's going to improve statistics and on it goes.
Yeah. And so when I give myself I was crippled by fear initially and did a lot of death scrolling, and a lot, I cried
Yeah.
out and made noises that I never knew a human could make, based
Yeah.
on fear. And you think of your kids, my heart broke for the women that have sat in the same seat that I've been in, but they would have done what was recommended, and they would have had a residual cancer on that contralateral breast, or a multifocal centric lesion in the breast. and they would have been looking at having it's 100% likelihood that there would have been a recurrence or a new cancer. And so I have committed myself to educating myself as much as I can and funding research, because when I had my exit at Lume, I know where much is given, much is expected. And I have invested with organizations that I feel hold promise for children, for in all different areas of medicine, and also other areas that went more around women's wellness. But this one, I finally felt like I can be public about this one. And because it is so underfunded, lobular breast
Yeah.
cancer received less than 1% of the funding. And I know my initial million seed round is not enough to really do much. But what the reason I came forward with that was, can I, as an entrepreneur, run a competitive process where we get applications that don't require 26-page, what do you call them?
Grants. Yeah. Well,
Grant
let's back
proposals.
up because people listening to this may not be aware of this amazing gift that you've just done. So why don't you tell us a little bit about what you're doing right now and the donation?
So just sickened by the fact that there's no targeted therapies specifically for lobular, and the screening tests that we do to hopefully get an early diagnosis just are suboptimal. In fact, 90% of women who are diagnosed with lobular on mammogram are not going to be a stage 1. And so that's a very scary statistic. And so how can we get better screening modalities? So I've invested at, MD Anderson on an AI study for earlier detection, have invested in some PR initiatives for the Lobular Breast Cancer Alliance to help get the word out more, because now there's an official Lobular Breast Cancer Day, which is October 15th. And could I help them with that? But then as I met with different researchers throughout, in different organizations, I realized that everyone's happy to take your money and they're real, to receive it, but it kind of sits in a pool and
Yeah.
it's
Hmm.
uncertain like how it's actually going to be deployed.
Hmm.
And I wanted to know that I was investing in targeted lobular breast cancer research. And I felt that the LBCA was the most kind of transparent and forthright in saying, this is all we do. This is all we are going to do. But this $1 million that I gave last week was historical for them. And I thought, that's kind of sad that for lobular breast cancer, that's the best that's ever been done. And it's
Hmm.
only $1 million. And so my hope is to continue to fund as we run a competitive process and get some promising action that we can fund phase 2 and 3 trials. Uh, but I'm asking for a match. And so if I could give like a shameless plug,
Yeah,
if
let's hear it.
yeah, so I gave the $1 million unconditionally, and at first I thought about running a match, so I'll match up to $1 million, but knowing that there's a lot of different groups that need,
Yep.
research as well, and everyone's asking for everyone's resources, but I do believe that people want to look for places to give. And so it's not a conditional match, but I'm asking people to help me match my 1 million to make it 2 million. And there's a likelihood if we don't reach it, I might match it. But I feel like the more people we can recruit in this process, the more people we get talking about it around their dinner table, the more people's ears are, kind of perk up when you hear lobular breast cancer. Like even celebrities that are diagnosed and talk about it, oftentimes they speak generically about breast cancer. And I want to encourage everyone, if they have been diagnosed with lobular breast cancer, to speak specifically to that cell type so that we can improve awareness and screening and treatments.
And I will say, I mean, I think when I always think about, I get asked a lot, where should I give or who should I give to? And I think I love donating to organizations that are using that money for research, where it's not just sitting in a pool. That money is going to fund research. And lobular breast cancer is always at the top of my list for that. The LBCA,
Oh,
the Alliance, is at the top of my list for that reason. And I
I love it.
also think that sometimes people think that their $20 makes no difference. But if everyone
Oh,
does that, right? There's a book that I read to my kids, what if everyone does that, or if everyone says that? And I think if everyone gives even a little bit, right? Instead of you going to Dunkin' Donuts for the day, you pull your coffee money and you donate to LBCA or wherever you donate. If everyone does that, imagine the power of that. And so I think sometimes, in this economy, people are scared to donate a lot because of, financial concerns, but even a few dollars makes all the difference.
Yep, a $10 or $20 donation is probably what will make it up in the end.
Yeah.
It's
If
going to be
everyone
that.
does a little bit of that. And I think that what's wonderful about research, I mean, research is wonderful in so many ways, but this conversation that we're having, imagine in 10 years if we can actually have specific recommendations for people with lobular, right? Where they're not forced to make these decisions of these unknowns. And I do want to stress, and I think it's important that there's probably people listening to this who have had a lumpectomy, and I don't want this to create fear of like, oh my God, I made the wrong surgical decision. Everyone makes the decision that is right for them at that time. But I think we take this and say, all right, we need popular focused research so that in 10 years or hopefully earlier, we've got good recommendations for people, right? We're better at where we are now. And I do think AI here might serve to be very helpful for screening.
And the breast density piece of it, I've
Yeah.
always wondered why, even as a gynecologist, why was it that, in practice, radiologists would report out heterogeneously dense breasts that
Hmm.
may be impacting, the
Yeah.
efficacy of this test to screen, but then they're not making a recommendation for the next best study. And in a way, they are the physician of record
Yeah.
and make a recommendation whether insurance pays for it or not, because oftentimes a cash price is way less than what they're billing insurance companies, and you can negotiate a lower cash price out of pocket, but we're
Mhm.
not even giving patients the option to go have that test done. So I'm so glad that now the FDA has changed the way
Yeah.
they
Report.
categorize breast, yeah, and report out on breast density, because I also had very dense breasts, and it's said it every year.
Hmm.
And, and I also, there were people who reached out to me that would saying, "Oh, you just need to take like ivermectin, and you should have had a QT study, and oh, come and do it." Oh my word! That and I,
Yeah.
it, there are people who are desperate and willing to do just about anything, but I think it's important that we
Yeah.
say mammogram for average risk women is still the best screening test that we have. And
And then we can add to that, but there's nothing into right now that is going to take the place of mammography.
yes, and so but it is critically important that everybody understand their risk,
Yeah.
and that you do a risk assessment personally, because 20% or higher really has bought you biannual imaging,
Yeah.
right? With an MRI, mammogram, maybe
Yeah.
ultrasound.
Exactly.
And my risk was way higher than that. But do you know what? I think I knew that too. And I was so busy running Lume
Yeah.
that Lume was, in many ways, I gave Lume everything, and I would have been willing to die trying for Lume. And I neglected my health. I had no balance in my life. My sleep was horrible. I was not moving my body. I was in meetings 12 hours a day and probably working an additional 4 with email and Slack, and just I I look back on that and I think I gave Lume everything. And so, if I hadn't, if when you go in and they update your family history,
Mhm.
why is it that nobody said, my physicians included, they didn't say, hey, you know what? You have a risk that's higher than 20%.
Yeah.
You need to be doing additional imaging. And I couldn't be my own physician in that, because I was just, they told me what I wanted to hear. Mammogram's
Yeah.
normal. Everything's
Exactly.
good.
And well, that's the thing. And so I just posted about breast density, and people are reaching out and they're saying, is this a new thing? It's not new, but we're finally
Oh,
talking about it. But I will still say, I live in a bubble, right, where I think everyone's being told their breast density and everyone's getting their breast cancer risk, and that's just not happening. And I mean, when I go to my doctor, do you think I'm a breast oncologist? No one is calculating my breast cancer risk. Like had to be like, hi, I've done breast. I'd like some additional imaging. Um,
mhm.
I had to ask for that. And so again, and I understand, people are going, they're being told you're fine, your mammogram's normal, you have no family history of breast cancer, and they're walking out the door, and that is it. And there's no conversation about risk, there's no conversation about breast density or supplemental imaging. And I think we have to, shout this from the rooftops that just because no one's talking to you about it doesn't mean that risk is not there.
Right. And I think maybe even like the way we think about maybe we need to do a know your risk campaign. Maybe I need to
Yeah.
fund that. Who wants to help me with that?
Yeah, and
And
I mean I love that. I mean this I will say there's been a big push in talking about it in the media because a number of the celebrities have who've been diagnosed have done it through the either supplemental imaging or they were at high risk, which then prompted a mammogram. I mean, it prompted an MRI. But
yeah,
we need to get that out to the masses. And part of it is it takes, and you know this as an OB-GYN, it takes time to do breast cancer risk. And the system unfortunately is not designed for now everyone to take that extra 10 minutes to do risk.
yeah. Yeah, and if it could be something, you know how when you take your kids to the dentist, you have to fill out all the
Yes.
paper.
Hmm.
Dentists actually do this way better than
Oh,
doctors.
they're great.
I think first of all, they're not as reliant on health insurance companies for everything that they do, and they're not having to answer. I want to
Hmm.
answer to the patients. I want the patient to be my customer, right? Like as a
Hmm.
physician, you want to get rid of all that red tape. But dentists do a very good job in requiring you to fill out paperwork prior to your
Yeah.
appointment. If you get there and you haven't done it, they hand you an iPad
Like you
and
sit
they say,
back down, you go fill it
yeah,
out.
you go fill that out. And so
Hmm.
maybe we need to be more diligent with that breast cancer risk assessment so that patients are filling it out ahead of time and it's just part of like blood pressure,
Yep.
weight. What's
And
your
that's it. Check in, you get the Tyrer-Cuzick or whatever calculator you want to
yeah,
use, and then you come in and it's like, all right, well, we need a mammogram. We see your breast cancer risk is 30%, so we need to be thinking about adding that MRI to it. And I think there are ways to implement it system-wide in health systems, but it's really an important conversation because we're seeing younger and younger breast cancer. And the big
oh,
challenge that I have is a lot of and so many patients are diagnosed and would be considered low risk by the calculator. So the calculators also need to get better. And
updated.
so I think there's a lot of work to do. I mean, some of the questions are still very outdated and talking about hormone therapy as a risk factor where we now know it's not as
Mhm.
simple and it's much more nuanced than that. And but it's progress. We're slowly, making those steps.
Yeah. And I think also just especially because, the screening modalities are not perfect and treatments are not perfect for every woman. And the fear and risk of recurrence and I know I'm doing this with my daughter and my children, that understanding the things that you can do just as a part of a lifestyle to reduce the risk for all cause mortality and not necessarily put a negative spin on it, but to say you're going to feel better,
Yep.
you're going to be stronger, you're going to
Hmm.
sleep better, you're going to think better, you're going to perform better, all of those things, and take control of that. That's the one thing that I did do immediately, made a 180 pivot in my lifestyle. And if it was not good for me, it was bad for me, and I eliminated it. And just
Hmm.
overall, just the working out and understanding, working out with intention, feeding my gut microbiome. That is one thing that I can control, and it brought me a lot of safety early on when I didn't feel like I had a lot in my
Yeah.
control. That I can control the way I'm living. I can improve my sleep, and even on an aromatase inhibitor. I know what everybody's talking about. I mean, I've been on it now for a year. And I wake up with joint stiffness is probably the one thing more than anything. And I was way more aware of my bladder on it than I ever was before, like a little bit more urgency.
Yeah.
But I have played around with Intrarosa and E-string and Vagifem, and I kind of have my cocktail that works best for me. And my bladder, I think, is back to normal.
It's great.
And I am in the best shape of my life because of the trying to minimize risk of recurrence and reduce all cause mortality, but also to live and thrive today in a better way.
I
uh,
think that is so important. I mean, I saw your post yesterday. You were lifting heavy. You said you feel the best that you ever have. And I do think lifestyle lifestyle habits are foundational, right? There is nothing that can change the power of movement, the power of good nutrition, the power of
yeah,
sleep. And I know it's harder on these medications 100%, but I think it is so inspiring to see people like you publicly online sharing what you're doing, talking about what you're doing, because I think it helps other people, know I can do this too.
Mhm. I need to talk about it more, I think.
Yeah.
Some of the vulnerabilities, though, I will tell you, estrogen's not everything.
Yeah.
And to your point, the
Mm-hmm.
most important lever you can pull is sleep, diet, and exercise, way before estrogen therapy, like hormone
Yeah.
therapy.
Mm-hmm.
And so, without systemic hormone therapy, I look at my grandma. She lived to be 101, and she was thriving up until about 6 months before she died. She was still up and around and baking bread and enjoying the goodness of her family and a good meal. And she had her memories about her. She was still 100% with it.
Mm-hmm.
And I look to her, and I've always felt like I have so much in common with her. I hope I get to live to be 101. And the thing that this rocked me to my core, where I thought, I'm probably not going to live to be 101 now. But now I actually think it's possible again. And
Mm-hmm.
I've turned this bus around and thought maybe breast cancer was handed to me for a reason that had much more to do with philanthropy and the way I treat my body now. And maybe I needed to make some tough decisions around putting boundaries around my time and valuing my relationships and my life, and saying no more than yes. And but knowing to say yes to the right things. Like I
Yeah.
think I've been called. I think I have been called to carry this and to do everything I can to advance lobular breast cancer research. It's one thing, but Lume, I thought Lume was everything. I created this new category that now everybody's copying me, and it's flattering. You need to take it as flattering, like Procter
Mhm.
and Gamble and Unilever
Yeah.
felt like,
Everyone
hey,
want. Mm-hmm.
I'll have what she's having.
Yeah.
And I do see it that way. But Lume was really just the catalyst to allow me to fund research, I think, in a really remarkable way. And this is just the beginning. And I'm trying to navigate it. Any advice you would have for me on how to navigate this, because this is not about me.
Yeah.
This is a much bigger plan that I have been called to be a part of. And, I think it's up to God. I think this is God's choice to, like even matching the million. I thought if God wants this to happen, it's going to happen. And if it doesn't, it's okay. The important thing is we're raising awareness and we're doing what we can.
And I
But
think and I think it's what you're doing is talking about it and sharing about it, right? I mean, social media has, there's pluses and minuses. We don't have to go into that, but I think the power of social media is the community and the community that exists in the cancer community is really just truly wonderful in so many ways. And I think it brings people together and having these conversations will inspire other people to say, okay, what can I do? And not everyone has to do anything. I always say that you don't have to but if you want to and you feel inclined, give a little bit, show up, even just share your story. That's doing something. And that's what everyone I think can do in some degree if they're comfortable.
yeah, everybody's story is so different. And the things that
Yeah.
are the most difficult to talk about are, how does this impact my relationship? How is this going to,
Mhm. Yeah.
breast surgery, it definitely robs you of a part of your identity as a woman. And even if, things just change and it's a matter of getting used to a new normal. But I was talking with my husband about it this morning, and we reflected on all the other different times in our life that gave us pause or created some awkwardness, right? Pregnancy creates intimacy, awkwardness for
Yeah,
some
of
couples.
course. Hmm.
Postpartum creates some intimacy,
Mhm.
awkwardness for couples. Certainly, as we age, as men age, and as women age, and the
Yeah.
perimenopausal chaos, awkwardness, menopause, breast cancer is just another thing that we have to work through.
Hmm.
And it's so important that you don't stop talking about it as a couple, and you continue to ask probing questions about what each other's insecurities or vulnerabilities are. Why are we resisting this? And why are we concerned about it, anything that might be holding us back from an intimacy perspective? And I think that's the only way you're going to get out the other side of it.
And I think that the conversations are hopefully helping people not feel so afraid to have these conversations. Years ago, and I always say this story, years ago when I started practicing, there was a 70-year-old oncologist and he was amazing. He was, everyone loved him, but he said to me, "You talk a lot about sexual health and vaginal dryness. I don't really understand why you talk so much about this. This isn't an issue."
Oh,
And I said, no,
Oh,
it
wow.
is. They just, people are not comfortable talking to you about it, and that's okay. But, and I think that now, and there's been a lot published on this and biases both on patient and provider side and fears of this communication. But I think now people are really starting to um, be open and saying, I can ask about my sexual health. I can ask about my body image. I can ask my partner, my physician, my healthcare team. And so I think we're a lot more open in recognizing what does cancer and treatment impact, and then talking about things like how do we fix it, right? We're talking about things like libido and vibrators and vaginal estrogen and sex therapy and all these topics that were so taboo and still
Yes.
are, but they're a little bit less taboo than they used to be.
Yeah. I think everybody going through this, if they are comfortable, should, even in the peri and postmenopausal stages where we've got so many things happening in our life that are such a huge distraction, kids growing up, a messy house, schedules, jobs, careers, poor sleep, all the things that sometimes a girl just needs all the help she can get, right? To just
Yeah. Hmm.
recruit herself into that intimacy space.
Yeah.
And I'm going to be so bold as to say, I think everybody should at least consider a vibrator
Love it.
because it makes it a certain thing for women. So often, if you look at the math between men and women and how often men orgasm during intercourse, it's 100% for most couples.
Hmm.
And women, it is single digits or
Yeah.
15% at the
Hmm.
most.
Yeah.
But when you introduce something that helps bring it up to speed for the female partner, it can be 100% every single time. And that is the thing that when I was in my 50s, I thought I'm having the best sex of my life with my husband. And it's because I now require my pleasure as well as his. And so unless he's willing to put the time in, this isn't going to be a 3-minute deal.
Yeah.
Like,
Hmm.
we're going to finish the job.
I love it. We could talk forever, but let's just tell me where people can connect with you online because the stuff that you share is really amazing, and I hope you continue to be open about it all.
Yes, and I'll continue. You can find me on Instagram, Shannon Klingman MD. And in my bio, there's a link if you would like to contribute to my Match the Million campaign for the Breast Cancer Alliance or for the Lobular Breast Cancer Alliance and help partner with me to help raise $2 million for that.
Amazing.
And
I will share all of those links. So again, it can be as simple as I'm not going to get coffee that day and I'm going to give it to LBCA.
I would love that. Thank you. It's just such a pleasure to talk to you.
Thank you.